When the Supreme Court overturned Roe v. Wade in 2022, New Jersey cemented itself as a safe haven state for abortion and reproductive health care services, putting policies in place to further protect access to care and those who seek it. Well, in the years since, research has shown that abortion in New Jersey has seen a sharp increase, with thousands of patients traveling from out of state to receive services here. A new report outlines how the state has managed that surge and where disparities exist across the state. Here to talk more about it is Laura Lindberg, professor at the Rutgers School of Public Health and co-author of that report. Professor, so great to have you with us today. That report was prepared for the New Jersey Family Planning League. But I just want to ask, your report looks at how the rates of abortion have changed here in New Jersey. What did you find?
So we found that the number of abortions in New Jersey have increased markedly since 2020. In fact, they increased 25%. There are other states in the country where the number of abortions is going up, but we're really increasing at a faster rate. And this increase in the number of abortions has coincided with an increase in the number of abortion providers. So that's important as the landscape for the ability to obtain abortion care has expanded.
I want to talk about the numbers just a bit. Close to 60,000 total, 59,780 abortions in 2024. That's the number that's up about 25%. 3,000 of those were out of state. So does that then show that New Jersey has become a safe haven state for abortions?
We definitely have people traveling from out of state to New Jersey. The majority of that is from nearby states, such as Pennsylvania, Delaware. But our clinics are telling us that people are traveling from as far away as Florida and Georgia, as their access and ability to get care in states outside of New Jersey has really weakened.
You also looked at where abortions are taking place in the state, where clinics exist, and the difference between those clinics. Break down some of that data for us.
So, with the expansion of the number of providers in the state, we see that more counties have a provider, but we have 6 counties in New Jersey that have no abortion provider, and most of those are in our southern part of our state. So if you live in South New Jersey, if you live in Cape May, Ocean County, and you have to travel to receive your abortion care, we're talking about challenges in getting transportation, time off from work, cost. There's not a great infrastructure for public transportation. So the lack of clinics in the southern part of our state is really detrimental to the ability of people in our state to get the care that they want and need.
Did you talk to any patients? Are you hearing from anyone who was able to express what that lack of access has meant for them?
Yes, when we talk to patients and when we talk to the providers who work with patients, what we hear are the pain, the emotional pain, the insecurity, the anxiety about having to get information, to make plans that fall apart as maybe the means of transportation. You thought you could borrow a friend's car and now you can't do that, or you realize you can't have the appointment the day you were planning and you have to ask work for another day off, or how are you going to arrange childcare? So everything that pushes people to travel, even within your own state, makes abortion harder. One thing.
Go ahead. I'm sorry.
I was going to say, balancing that or offering some escape valve on that is that we have expanded the number of telehealth providers. So that lets people get medication abortion online and not without a need to travel to an in-person appointment at a clinic.
Who is paying for these services? We know that anti-abortion proponents have said that using state subsidies for these types of services is a misuse of taxpayer dollars. Who is paying for it?
So we didn't get into that deeply in this report, so I can't give you specifics, but it's certainly a mix of payer types. That may be people's private insurance. That may be that they have public insurance, such as Medicaid. That may be philanthropic donations, whether to specific clinics or more broadly even to patients that are coming from out of state.
Your report does detail a number of recommendations for the state and federally, too, I guess, because one of those is an increase in Medicaid reimbursement rates. What would you like to see there specifically? Is this for the clinicians? Is this for the patients?
So this is to facilitate patients being able to get the care they need by making providers able to provide care at later gestations and for more complex cases and get the reimbursement that matches what it actually costs them to provide that care.
Because the later the service, the more costly?
Yes, it's more time consuming and involves more staff, et cetera.
You also would like to see no clinic operating at a loss for offering abortions. Is that happening right now?
Certainly. I mean, we have clinics that are able to provide their care at the to people who need it because of donations, and that is a difficult path to go down and is not secure in the future.
You also want to see no patients having a delay in care. You got into what it means and what it takes for patients to get to clinics, but based on their inability to pay, you don't want to see those delays happen. Explain what's happening there and why that's a recommendation you made.
Because what we don't want is where patients call up, or worse yet, even get to a clinic and discover what the cost is and say, I don't have that money, I'm going to have to go home and figure out how to get that. It's going to take me a week or two. Or I have the money to travel and I may have to take a day off from work and I'm going to lose my income for that day, but now I don't have enough money to pay for the service. And these are the daily struggles and trade-offs that patients have to make.
How much does it cost, and is it different for procedural operation versus medication abortion?
It really varies clinic to clinic how cost is done, so I can't really answer that specifically.
And of course, you mentioned the counties, 6 in New Jersey, that still don't have a clinic. Did your report detail how those counties could open clinics or expand what they're offering?
Yeah, so we know there has been some expansion. So one method that's happening is an existing clinic has been able to open a satellite clinic, so that's helpful. We have a provider who's going to be opening a clinic in Hudson County where there is no clinic now. And think about how many New Jersey residents live in Hudson County, and yet we have no provider there. So the ability and drive to open a new clinic will help to meet that need.
All right. Laura Lindberg, professor at the Rutgers School of Public Health. Thank you so much for being with us today. Appreciate it.
Thank you for your interest.
And that's going to do it for us. I'm Joanna Gagos for the entire team here at NJ Spotlight News. Thanks for being with us. We'll see you right back here tomorrow.